Welcome to the ECG Management Consultants and Foley and Lardner Pediatric Business and Healthcare Delivery Series. Today's topic is titled Pediatric Healthcare Delivery, the State of the State. Serving the pediatric population remains one of the most complex challenges in healthcare delivery. Children's hospitals, pediatric programs, and physicians face economic uncertainties as elements of the legal and regulatory landscape change and healthcare payment and care delivery reforms begin to take shape. While a great deal of attention has been paid to Medicare and the Medicare ACO effort, equally important is the application of the triple aim principles to those at the beginning of the healthcare delivery spectrum. ECG and Foley have partnered to kick off a new webinar conference series that will explore the most important business and structural challenges to pediatric healthcare delivery. Hello, I'm Ken Rorda, a principal with ECG and leader of our firm's children's healthcare practice. I'm pleased to be your co-host with Mark Waxman from Foley and Lardner and one of the speakers for today's webinar. Before we introduce today's speakers, let's go over a few details about the webinar. It's 90 minutes in length. The first 70 minutes of the program is a presentation, followed by a 20-minute question and answer session. We have emailed all participants a copy of the slides that will be shown throughout this webinar. Note that attendees are participating in listen-only mode, but if you have questions, you can type them into the question and answer pane located in the toolbar on the right of your screen at any time. At the end of our formal presentation, the speakers will answer as many of your questions as possible. We will also be polling the audience a couple of times during the webinar after a bit larger sections, and we hope you'll participate by simply clicking on your response to the question that appears on screen. Finally, upon exiting today's program, you'll be directed to an electronic survey. Your feedback is important to us, so please take a minute or two to complete this survey. So, to get us underway, I'd like to introduce Mark Waxman. Mark is a healthcare partner with Foley and Lardner. Mark will start us off with an overview of today's agenda and the series in general, as well as a few words about Foley and Lardner. Welcome, Mark.
Yeah, thanks, Ken. First, let me say how much we appreciate all of you joining our webinar program today. There's been, as Ken noted, an awful lot of discussion about the Medicare Shared Savings Program, Pioneer ACOs, Medicare Advantage contracting, the challenges of reform and costs, but by and large, much of that, if not all of it, that typically fills the airwaves has been focused on the adult and the senior adult population. Having worked in the pediatric area, we looked at this, contacted and spoke with ECG and said, you know, we really think that there's another area here that deserves more attention that it's getting. It's an important area. It involves, obviously, our futures. It involves certain high-cost areas. It involves its own dynamic. And we really need to bring more coverage in this area to those involved in this particular delivery space. Hence the creation of this webinar series. We've currently scheduled it as a series of 6 with a number of topics that we'll introduce you to through the program. And we hope you are interested in it, enjoy it, and we would invite your comments, suggestions, and insights with respect to each of the areas that we intend to cover. If there's additional areas that you think would be a great area of focus, just let us know, and we'll try to accommodate that in a future session as well. One of the things that we wanted to do as we brought this program forward was to make sure that varying viewpoints were heard and we create balanced programs. So you'll see in today's program, you know, very important viewpoints from both the provider sector and the National Association of Children's Hospitals through Dr. Jim Kaufman, and the payer sector with Dr. Peter Bowers from Anthem Blue Cross Blue Shield. The idea is to kind of get the perspective from those who provide the services and those who pay for the services. And that focuses on the business side of pediatric and healthcare delivery, which is really designed to be the emphasis of our program today. So I've introduced you to Jim and to Peter. We'll hear a little more in a minute, and to Ken and ECG. And let me just say our agenda today is, you know, we're going to talk about the policy perspectives, try to get a sort of a big picture view from the provider side of the table, calling on the National Association of Children's Hospitals to lead us through that. A big picture view from the payer side of the equation and the third-party payer piece of this with the Anthem Blue Cross Blue Shield and Dr. Bowers. We then want to introduce you to our future sessions and some of the issues that we will be talking about as we move forward, and then really open this up for discussion among all the participants as to just what is the state of the state, where is it that we kind of think we're headed as we move forward into this arena. So you've seen sort of, here's the agenda on page 2, and we move forward with who we are in the pages 3 and 4 of the slides. And then, Ken, let me turn it back to you for the more specific introductions.
Thanks, Mark. You can see the bit of detail on Foley and Lardner and ECG, and a little bit about the Pediatric Business and Healthcare Delivery series that Mark just spoke to. But maybe I'll start with specifically introducing our speakers. Our first speaker is Jim Kaufman. Jim is a seasoned healthcare public policy expert dedicated to quality improvement and access to health coverage for all children. Jim took the helm of the National Association of Children's Hospitals in July of 2008 as Vice President of Public Policy. Jim has oversight of the association's federal advocacy agenda and all state policy information. Prior to joining the NACH, he served as Director of Government Affairs for Johns Hopkins Medicine and Director of Government Relations for the Johns Hopkins Institutions. Jim holds a Master of Public Administration from the University of Baltimore and a PhD in Public Policy from the University of Maryland, Baltimore Graduate Schools. Welcome, Jim.
Thanks very much, Ken. Greatly appreciate the opportunity to present today.
And briefly, our second speaker is Dr. Peter Bowers. Peter is the Medical Director of Payment Innovation at WellPoint, supporting market transformation in 14 Anthem Blue Cross Blue Shield plans that collectively provide coverage for over 34 million lives. Previously, he has served as Regional Vice President and Medical Director for Anthem National Accounts and has also served a Lead Medical Director for the Connecticut marketplace. Prior to joining Anthem, he practiced pediatric cardiology at Yale for over a decade. He also ran the fellowship training program, and his research career focused on identifying genetic causes of SIDS and congenital heart disease. Welcome, Peter.
Thanks, Ken. Pleasure to be here.
So with those introductions, thanks again, everyone, for joining us, and I will turn it over to Jim to speak to Section 2, the policy perspectives.
Thank you very much. And as was noted, I'm going to talk a little bit about the policy environment that the children's hospitals are working in. And one of the things I'd like to start off with, you've heard about the National Association of Children's Hospitals. We actually just merged with our sister organization in Kansas City recently and have a new name. So you'll hear me refer to the Children's Hospital Association as well. We just got approval to use that name this week. So the first slide, on slide 9, we really focus on the policy framework in 3 major areas. One, looking to reform the delivery system to better serve the needs of children. Second, to advance educational support for the next generation of physicians. And third is really looking at research opportunities not only that improve the delivery system, but also improve care overall. Because the children's hospitals, when you look across the country, they really serve a tripartite mission of patient care, education, and research. The next slide, slide 10, really kind of gives a picture of the number of hospitals that we're talking about. When you think about children's hospitals, we're actually a very, very small number of hospitals across the country. There's approximately more than 5,000 hospitals overall, but there's only about 250 children's hospitals. And those 250 children's hospitals really fall into 3 buckets of organization. One, freestanding children's hospitals like the Children's Hospital of Philadelphia, Cincinnati Children's Hospital, or Children's National here in D.C. That accounts for about 50 of that 250. And then there's another 50 specialty hospitals that serve very, very unique niche populations like the Kennedy Krieger Institute, Children Specialized up in New Jersey. And then the remaining 100 hospitals are roughly what we refer to as hospitals within hospitals. Johns Hopkins, Duke, UC San Francisco, where the children's hospital is under that larger umbrella. But while that's only about 5% of the nation's hospitals overall, they really are the backbone of the entire pediatric healthcare delivery system. And that bar chart really shows that when you're looking at the children's hospitals, they're the ones that are providing the high-end complex care to those children. And when you start to think about the complicating services such as organ transplant, the children's hospitals are pretty much providing all the services for that population. So when you really think about the children's hospital, they're small in number, but very, very important in the overall children's healthcare system. The next slide I really think paints the environment that we're looking for. Slide 11 is the average payer mix for the typical children's hospital. And what you see, a lot of people are very surprised at when they see Medicaid accounting for 50% of the normal inpatient days at a children's hospital. And that's very, very important because most people, when they think of Medicaid, they think of Medicaid as only for the poor and a very small number. And often people say, oh, a typical hospital, Medicaid, 10%. Most people are very, very surprised when they realize that a children's hospital is more than 50% Medicaid. Now, moving to the next slide, this is really painting the environment that we're going to be dealing with in D.C., and I'll get to it at the state level shortly. This is actually a bar graph showing the deficits and surpluses from 1980 to 2021. The light green bars are actually showing the forecast from the Congressional Budget Office, and the dark blue bars are from the Office of Management and Budget. What this shows in D.C., the overarching theme we're going to be dealing with is cost containment, budget cuts, fiscal constraint. The overarching effort is how do you reduce the amount of federal expenditures that are going on. We all know earlier late last year, the super committee that was identified, those 12 members of Congress that were identified to find $1.2 trillion in cuts, failed in their efforts. But the one thing I want to point out, if you look at the last dark blue bar on there, that's basically $1.2 trillion. So what we're really looking at was the super committee could not reach agreement on basically 1 year of shortfall. And the other thing that's important to note is those light green bars in the out year, those projections, that is what they call baseline budget projections, assuming all things in current law actually takes place. And we know there's a lot of discussion right now on Capitol Hill about other things that are going on. One in healthcare is the Medicare physician or the doc fix. If Congress does not take action next month, physicians serving Medicare patients will see a 30% reduction across the board in their reimbursements. Everybody on Capitol Hill knows that will not take place. However, the fix for that, which is over $300 billion, is not included in the forecast. The forecast also assumes that the Bush-era tax cuts will expire, which generally people on the Hill believe will not take place. So those numbers will actually be much worse than they are. And then also the statement by the Federal Reserve yesterday notes that the economic recovery is going to take many, many years. So this is not a 1 year or a 2 year situation where we're going to be dealing with budget shortfalls. It's going to be a many, many year issue. And there's going to be a lot of talk on Capitol Hill this year and for the next several years about cost containment in healthcare, and Medicaid will be a big part of that discussion. Now, since the super committee did fail on slide 13, what we're looking at right now is a sequester or across-the-board cuts that will start January 1 in 2013. And basically every section of the federal budget will share in part of those budget cuts. Roughly, you're looking at across-the-board 10% cuts annually for the next 10 years in the Department of Defense, non-Department of Defense security, non-defense spending. So you're talking National Institutes of Health, CDC, Children's Hospitals Graduate Medical Education Program. Basically, every program out there is going to be looking at massive budget cuts. Medicare was actually exempted from those larger cuts and are looking at about a 2% cut or $123 billion over the next 10 years. Unlike these other programs, actually, Medicaid was exempted from the sequester. And I'll get into a little bit more why, but because of that, actually, Medicaid is going to be targeted as an offset for other cuts. For example, Governor Romney mentioned using Medicaid as a pay-for to avoid the Department of Defense cuts. Senator McCain has also noted that. Eric Cantor, the House Majority Leader, also talked about how we should be avoiding Department of Defense cuts and looking at other places in the budget, and many are specifically noting that Medicaid could be used as a pay-for. Now, when you look at what's going on at the state level, this is why I think Medicaid was actually exempted out from the across-the-board cuts at the federal level. The graph on page 14 shows that at the state level for the past 5 years, general fund spending, which is depicted in red, has actually been outpacing general fund revenues. And that's very, very important to understand because 49 of the 50 states have to balance their budget every year. They cannot run deficits like the federal government does. And when you look at the next slide, it's important to understand that the single largest expenditure at the state level is Medicaid. It outpaces education, and really the only other category that's out there other includes transportation, it includes criminal justice system, National Guard, other those type programs. So Medicaid becomes a large target. And state legislators, when they start looking at balancing their budget, Medicaid, which is perceived as only for the poor, becomes a major target because they would rather cut the Medicaid program for the poor versus K-12 education, which affects their entire state. On the next slide, we always try to remind folks that while the perception is that Medicaid serves only the poor, the bar graph on the left shows that enrollment of total enrollment in Medicaid, children actually account for about 50% of the total enrollment. However, the bar graph on the right shows that while children make up almost half, we're actually a relatively inexpensive population. Most kids are relatively healthy, so overall, Medicaid expenditures for children are only about 20%. So the real cost driver that you see there is actually for the age and the disabled populations are the ones that are growing very, very rapidly. The one thing I'd like to note with Medicaid is one of the challenges that we often see, while in DC everybody talks about Medicare and there's always lots of national data that talks about Medicare and how you can look at things, people forget that Medicaid is actually a state-dominated program. While there are certain federal requirements, the states truly have a lot of flexibility in dealing with their program. And even when you look at the amount of money that goes from the federal government to the states, there's great variation. The map shows that the average expenditure at the federal level to the states for their Medicaid program is about 57 cents. So for every dollar a state spends on Medicaid, about 57 cents is coming from the federal government. But it really ranges whether you're in California, a wealthy state, they're getting 50 cents on the dollar, to places like Mississippi and Alabama that are getting closer to 80% of their Medicaid costs covered. Now, while there's a lot of variation in how much money the federal government is giving them, the next slide actually shows that there's also a lot of variation in how much money the states are spending for various populations. When you really look at it, the U.S. average per Medicaid enrollee is about $5,000 per year. The U.S. average expenditure per kid is roughly $2,000. But even there, and these are a few states that show there's wide variation in there, with places like Maryland spending a little bit above the average, while places like California are spending significantly below the average. This variation is driven by lots of different issues, and one of the biggest issues that's really driving that variation is the next slide, which is slide 19, that gives you just a small taste of the variation. People often talk about Medicaid and how different it is. I really think this helps paint a picture. The average Medicaid expenditure, or the average reimbursement for a service, Medicaid to Medicare, is about 30% below. So if Medicare is paying $1, on average nationally, Medicaid is paying about 70 cents. But even when you look at this, this is two examples of a typical patient visit versus a surgical procedure. You start to see the variation showing up very, very quickly. For example, in California, Medicare is paying roughly $50 for a new patient visit. Medicaid's only paying 50 cents on the, 50% of that, $25. In New Jersey, when you look at that surgical procedure, while Medicare is going to pay close to $600 for that procedure, they're only paying $184 for the exact same procedure. Now, it's important to note, many times you can find an auto mechanic to do a brake job for $185, but now you're asking a surgeon to do a major surgical procedure for that dollar amount. This is truly a major problem, and these numbers are actually from fiscal year 2008, the most recent data that we have. And this is before the states have been adopting massive provider reimbursement cuts over the past several years due to their financial challenges. The next slide really notes on slide 20, when you talk to the National Governors Association, what they're seeing with Medicaid, the dominant theme for the upcoming fiscal year is cost containment. What we're expecting is Medicaid provider reimbursements will be cut again in FY 2012. 46 states plan to reduce hospital and physician reimbursement rates. Also, the states are dealing with many, many challenges with Medicaid and trying to upgrade their systems to deal with changes coming from the Accountable Care Act, looking to control overall growth in the program, when the overall growth in healthcare is expected to be going up about 10% for this fiscal year for Medicaid. Also, they're trying to figure out what they're going to be doing with that to try to control the growth even more, because while they've been cutting, the past several years they've cut most of the easier cuts out of the Medicaid program. They can't change provider excuse me, they can't change the eligibility system because of the requirements in the Accountable Care Act. So they're really looking to move to more managed care and also system delivery reforms to try to improve the system. And this is one area that I should note. The children's hospitals are trying to work with their state Medicaid directors and their governors to really be part of the solution, looking at pediatric accountable care organizations, medical homes for children with complex conditions. What we don't want is just across-the-board cuts that really do not make improvements to the delivery system or that would greatly reduce children's access to care. On slide 21, we'd like to point out why on Capitol Hill there's been a lot of talk about cutting Medicaid. Last year there was talk about a block grant of Medicaid that would reduce expenditures by $700 billion to the states. The White House originally proposed $100 billion in Medicaid cuts. What we kept reminding folks on Capitol Hill is while only Capitol Hill can cut Medicare, the states have been cutting Medicaid. As I noted, 46 states this year are going to look to cut provider reimbursements. In the fall, the Office of Management and Budget actually released a report noting that in the report, because of basically state actions, federal expenditures in Medicaid went down by $3 billion in FY 2011, and their forecast was federal expenditures would go down by almost $100 billion over the next 10 years. This is predominantly due to state actions because of those budget cuts that they've had to adopt because of shortfalls in state revenue. On slide 22, again, I just want to reinforce that the children's hospitals are really, because Medicaid is by far our largest payer, we just don't want to see cuts across the board. We're really working to try to improve the system, and we've been trying to get national standards adopted as well as having the states work to try to figure out ways to improve things. One of the things we're actually working to try to advance right now is taking examples that we've seen in Wisconsin, Arkansas, and Florida to really look at medical homes for children with complex medical conditions, change the payment structures to actually make those models financially viable and expand them. This is something we're trying to work with the Innovation Center as well as Capitol Hill to gain that support to replicate these programs and move them nationally so that 1% of the pediatric population that's accounting for 30% of the expenditures, we can improve the care coordination and reduce costs while improving quality. Also, we were able to get a provision in the Accountable Care Act to create pediatric accountable care organizations. And that is something we're continuing to try to work with CMS to see if there's opportunities to advance that. As Mark noted early on, there's been a lot of focus about Medicare ACOs. We would like to see pediatric ACOs also advanced in that effort. Finally, the children's hospitals are doing a lot to try to reduce infections and improve quality. And one of the things that we've done together is about 60 children's hospitals have worked to reduce infection rates and have saved over $100 million over the past 5 years by improving care. Now, what's important to note there, on adult medicine, there's been a lot of federal expenditures to support those quality initiatives. Our effort that saved $100 million had no federal dollar support at all. So this is something that children's hospitals are really working together to try to improve the clinical care for children. On the next slide, one thing I need to mention is one of the challenges that we're also facing is related to the provider training. Generally, when you talk on Capitol Hill about healthcare providers, there's a perception that there's an oversupply of specialists and a shortage of primary care providers. Well, in children's healthcare, actually, we see an opposite problem. We see a national shortage of pediatric specialists and regional pockets of primary care provider shortages. But one of the things that's a little different in children's healthcare, there's 50 freestanding children's hospitals that account for about 1% of all hospitals in the country. However, they train almost half of the pediatric specialists and the general pediatricians. One of the issues that we have while in adult medicine, Medicare provides graduate medical support to those hospitals to train the next generation of providers. Those freestanding children's hospitals don't have Medicare patients generally. Therefore, Congress created a separate training program 10 years ago, the Children's Hospitals Graduate Medical Education Program, to support the training of that next generation of pediatric providers. Well, to give you an example of how challenging it is and how people in D.C. truly do not understand children's health care, last year in the President's FY 2012 budget, he proposed to eliminate the CHGME program because they wanted to redirect the money towards primary care. And we had lots of fun pointing out that the last time we looked, general pediatricians are primary care providers. And we wanted to make sure that the President did not make that same mistake again this year in FY 2013, and we are truly hopeful that the President includes funding for that program. Also, we're trying to get the program reauthorized. That legislation is currently waiting final action in the Senate. But even though the President in FY 2012 proposed to eliminate funding for the program, the House and the Senate both recognize how important this program is for all children and actually level funded the program at $268 million, even though other programs were significantly reduced. On slide 24, I list some of the challenges and opportunities that I see as health policy changes that are coming down from the Accountable Care Act and some fiscal issues. And I think this really sums up some of the challenges that we're going to have today and for the next several years. First of all, when you look at Medicaid budget cuts, as I mentioned, on Capitol Hill, there's a lot of discussion about using Medicaid as a pay-for to avoid some of the sequestration cuts to the Department of Defense. But even before that, the President proposed $100 billion in Medicaid cuts. The House budget resolution last year called for $700 billion in Medicaid cuts. What's important to note, we actually oppose both of those efforts because those cuts are not going to improve the Medicaid program. All it's going to do is cost shift the cost from the federal government to the states. And as I noted throughout the presentation, the states are already cutting Medicaid services. They're reducing their payments to providers, and those payments are already significantly below Medicare. There's been numerous reports out there showing that as Medicaid cuts take place on providers, they either limit or close their door to Medicaid patients. Therefore, their access to care is greatly impeded for those children that have a Medicaid card. Kind of shifting to what's going to happen in the future with the exchanges and changes to Medicaid and the Children's Health Insurance Program, this is something that I believe needs a lot of attention. There's talk about these exchanges and how they'll be operational in 2014. But how do they intersect with the Medicaid program? Kids, because they're generally covered by Medicaid, if their parents' income changes, how will the exchanges fit there? How will they change from plan to plan? Also, what is the future of the Children's Health Insurance Program? The Children's Health Insurance Program has to be reauthorized in 2015. So one of the questions that's going to happen is how does the CHIP program and the exchange programs all fit together? An important part of that discussion is the essential benefits package. What services will be included in there for children? There's a guideline that was just issued by HHS a few weeks ago that noted that the state should really identify their essential health benefits package for the exchanges. One of the concerns that we have is children actually have very unique health care services, and one of the things that we want to make sure, like in the statute, it requires these plans to include unique pediatric services, including vision and dental. And we're really hoping HHS reconsiders their initial guidelines and puts greater clarification in what should be included in the essential benefits package. One of our greatest concerns there is children's hospitals. We don't serve one area or one Medicaid program. The children's hospitals are much more regional providers serving multiple states and in some cases the entire country. Because of the variation in Medicaid from state to state and now are concerned with the potential variation under the essential benefits package in the exchanges, you create tremendous administrative costs unnecessarily because of the variation in how a state deals with its Medicaid program and now how a state may be dealing with its exchange programs. One of the other areas that we want to talk about is continue to figure out how can we work with the states, CMS, the governors, and Congress to really help improve the healthcare delivery system for children, which will require changing payment methodologies. As I mentioned, those medical homes that we see in Wisconsin and Arkansas, both of those programs have shown savings to the state. The Arkansas model showed $5 million annually in savings to the state Medicaid program, but actually the hospital lost money every year on that program because the reimbursements did not cover the services that they were providing for care coordination. So this is a constant challenge to really improve the system. We can't just look at the delivery system. We need to look at the payment system as well and how they intersect. And finally, as I mentioned, we have challenges with healthcare professionals, and we need to make sure Congress funds that CHGME program that provides support for the training of almost half the nation's pediatricians, and also ensure that program gets reauthorized. Also, as they continue to look at changes to the greater graduate medical education program, we need to make sure that there's recognition that while some may believe there's a shortage of specialists, that the challenges in children's health care and the shortages that we're seeing today are not inappropriately addressed or swept up in some bigger policy changes. So with that, Ken, I'd like to open it up for you and see if you can put out that first poll question.
Thanks very much, Jim. With his presentation in mind, please take a moment to respond to our first polling question, which is coming up on your screen right now. And the question is, how is your organization responding to your state's Medicaid policy and reimbursement changes? Please respond by clicking on those responses that best apply to your organization, and you can pick more than one. The potential responses include no response, implementing care protocols to control cost and improve outcomes, reducing services in areas that are financially challenging, expanding services in select areas, and finally, seeking partnerships with other pediatric providers. We'll provide the results in just a moment. It's interesting with Jim's introduction, and again, Jim, thank you for that. I'm sure a number of our attendees today have experienced very closely a lot of those state budget discussions and Medicaid cuts almost on a daily basis over the last year to 2 years, as we've learned of state budgetary crises and solutions within the Medicaid programs in order to meet budgetary shortfalls. But we really have seen a wide variety of solutions, from just pure across-the-board cuts to some of those more innovative discussions that Jim introduced. I will say also, of our attendees today, we do have a good mix of those organizations that Jim spoke to, including freestanding children's hospitals and programs, those within academic medical centers, and those hospitals within hospitals as well. So maybe we'll give another 5 or 10 seconds to the poll, as those of you who are just completing it. Again, you can pick more than one. Okay, why don't we go ahead and close the poll. And the results are, again, to the question, how is your organization responding to your state's Medicaid policy and reimbursement changes? 14% are choosing no response. 68% are choosing to implement care protocols to control cost and improve outcomes. 25% are reducing services in areas that are financially challenging. 46% are expanding services in select areas. And 54% are seeking partnerships with other pediatric providers. So clearly there's a multifaceted strategy to responding to these Medicaid policy and reimbursement changes. But it looks like the majority are looking at care protocols and cost control and outcomes improvement, as well as partnerships, seeking partnerships with other pediatric providers. Jim, any ideas or comments on this? Anything surprise you?
Actually, I have to admit it doesn't surprise me, because with the children's hospitals, I mean, we're clearly mission-driven, and we're going to serve all children. And this is why we've been talking about how children's hospitals want to be part of the solution. So when you see 68% are working on care programs, care protocols to reduce cost, it shows that they want to continue to provide those key services that children need and are working to reduce healthcare costs. So that doesn't surprise me, and that's the message we keep trying to deliver on Capitol Hill, that just cutting across the board doesn't make sense. Work with us to try to figure out ways to improve the system overall.
Yeah, very good. Okay, so thanks, Jim, again, and let's move on and open the floor to Peter Bowers now as he shares his thoughts on third-party payer perspectives. Peter?
Thanks, Ken. Appreciate it. And thanks, Jim, for a terrific review of the current state. And I think I would start by discussing the poll and would say that it's a great key-in for my comments. And specifically, I think that the idea of partnering and looking at both cost and quality outcomes resonate particularly for where we are philosophically. And I think that while my comments are going to be starting very globally. I will try to be as pediatric specific as possible. As I think you heard from my introduction, it's something that's near and dear to my heart, having spent many, many hours in Children's Hospital taking care of these types of patients. And that said, I think I'm going to step back and look at the more global picture from a sizable commercial payer, with some comments to level set, and then also get deep into things that are pediatric specific whenever possible. And I think that that's sort of framing my comments here. I think that when we look at what we describe as payment innovation, and I would say that you could start by calling it reimbursement transformation or reform, if you will, but it's much more than that. This is about a journey of healthcare delivery reform. And I want to touch on the second part when you talked about partnerships. And while the first poll question may be touching on partnerships that you think of as sort of between delivery partners, for example, it could be between children's hospitals, it could be between federally qualified health clinics and Medicaid, as one example. I think that you need to begin to think even more broadly than that. And what I mean by that is, as we go through this process of challenging economic times, and several slides into my presentation will be articulating what that really looks like, and the economic imperative that Jim touched on, but I'll be coming at it from a different angle. I want you to be thinking about how we are going to all together as different stakeholders in our current system are going to have to interact differently in many different areas, in many different ways, both contractually, financially, clinically, data exchange information, but also I think culturally. And if I had to pick one of those that matters the most, I think the culture is going to be really critical for thinking about what will be successful in this new world. So that said, I want you to start with our slide 27, that we are moving away from volume reimbursement regardless of how old you are or how your healthcare is funded, to a value-based payment. In the United States, we don't have everybody in our system, as everybody well knows. In general, about 50 cents of healthcare spend comes from governmental funds, or tax base, if you will. That's Medicare and Medicaid, as you well know. And while that's crossed over the 50% line just recently, about 50% of funded activities come from a commercial base. And we have lines of business in all of those types of funding revenues. Within commercial, as you probably know, there are fully insured products today in the commercial space. That is something where companies such as Anthem hold the financial risk. And there are others, which is an increasing majority, that are self-funded, where we provide ASO funding arrangements, or administrative services only. So that means for a large, sizable national account, you can pick an example like an IBM, Verizon, that are the easiest one to be thinking about. They actually hold the risk, and we administer on their behalf and work with the network to improve, both patient safety, quality, and outcomes, and also reducing healthcare cost trends on their behalf. So we're sort of stewards of their money rather than holding the risk ourselves through premiums, as you might imagine. So with that, I'm going to go ahead on to the next slide, which is, in general, I want to describe what we see as accountable care, which is the path forward in this headwind of economic realities and challenges that Jim was alluding to. And clearly they are there in pediatrics. No one can deny them. Critically important. But if I look at our gears here on this, the three major domains that we're going to be looking at are sharing differently than we do today, data, as well as other capabilities to reduce the challenges that it is to deliver healthcare. And in particular, changing the financing of it to reward coordinated care across the delivery spectrum, away from just simple utilization-driven or volume-driven to getting to outcomes, and tying increasingly dollars to that in the areas of chronic disease management, wellness, prevention, et cetera, because right now we are still way too heavily dependent upon episodic interventions. Clearly, for a pediatric-oriented audience, this has been something that is core to our DNA, if you will, but and we do it better than the adult population. But that said, we still have opportunity there. And I think touching on that, we're going to be also increasingly, whether it's virtual or embedded, be assisting the delivery system, not doing the delivery, but empowering it through things such as virtual case management, much more so today, much more integrated than the sort of matrix environment we are in today, and I think at a deeper level for those that really need care coordination. I'll be talking about that as well. We'll be sharing some of the things and assets that health plans possess. So population health management of data, predicting modeling, proactively who is at risk for these types of interventions, and sharing that with the delivery system, because we still today don't really do that well. And in addition, clinical information that, for example, as a hospital you own, we welcome that bidirectionally coming back to us, because our overall way forward to get at some of these opportunities in the fiscal headwinds are getting coordinated care to get the right services at the right setting, at the right time, so that we also can increasingly, now this is even more challenging, meet what their individual health care needs that's culturally sensitive, patient-centered in its orientation. Because quite frankly, the delivery system that we have today does not do a particularly excellent job at that task. So high-level comments about how we're changing that. So let me step back and think sort of on a large-scale basis. Some facts, and this is from a white paper that's Thomson Reuters. There's several of these. This one we think is actually a little closer to probably reality. There are those that are more aggressive, and it's not that this is perfect, but just trying to scope the overall spend. If you look at the facts of the 2.5, that's actually trillion dollars, not $1,000, spent in the U.S. today, about 30% of it conservatively is estimated to be waste. That's about $700 billion annually. If you think about how much money that is in relative to what it would take to keep the pediatric programs trained, create adequate staff, to keep state budgets from bellying up, if we can pull out that waste. Now that's not something that's a trivial statement, as we'll get to in a second, but that's a huge opportunity. For my company in particular, covering 1 in 9 Americans, and across our Blue Cross Blue Shield Association, we cover 1 in 3 Americans. So we have about 33% of Blue Cross Blue Shield under the Anthem Blue Cross Blue Shield plans. For us, in and of ourselves, 30% of our spend is over $70 billion ourselves. So where is this waste? Can we really get it? Is it actionable? And how actionable is it? I will share with you and acknowledge that there isn't anyone in the delivery system today who doesn't have a role in creating that waste. Everyone has that. My own company as well, and clearly number one on here is admin system inefficiencies. That is there. The last one that I won't be touching on, because it's not as much directly clinically oriented, although it is indirectly clearly related, is fraud and abuse, where there is clear significant opportunity. But if you look at the types of waste, and if you want to get deeper into this, which many of you might want to, take a look at this white paper from Thomson Reuters. But 2 through 5 are clinically very directly, in particular the unwarranted use. These are things like the evidence-based medicine. How do you create a system that doesn't have to practice defensive medicine? How do you do better care coordination than the fragmented episodic system that we have today? How do you get preventive health care before people? Because quite frankly, we're really good at taking care of somebody after they get significant disease, so reactive health care, or sick care, as I'm sure you've heard. We need to do better at getting upstream at the root cause. Non-trivial and real challenges, but that's the journey, and that's also where the sustainability will come from. That said, what I want to go into is a next slide that is from actually Paul Grundy, who is a physician who works for IBM. Many of you may know Paul. He's quite visible, and I have a slide deeper in my presentation talking about the PCPCC, the Patient-Centered Primary Care Collaborative, which you ought to think of as a multi-stakeholder entity that is clearly targeted on reinventing primary care. And as Paul would like to say, taking the doctor and patient, putting him in barbed wire around the fragmented, expensive and at times dangerous healthcare delivery system we have in the United States and letting them take care of that. So reinventing primary care fundamentally is something that we at Anthem believe very strongly is, and I will be touching on that in just a second. This slide, though, before I get there, I want to really impress upon, Jim talked about the fiscal realities at the government, policymakers, federal level about how federal dollars flow to states, but state budgets and how they influence Medicaid are laser focused. This is a different slice on the economics, and this gets into sustainability and jobs. So if we look at how much we spend as a country relative to the rest of the world, not only do we not get a good outcome, but it's way too expensive. So this graph is pretty complicated, but there's a lot in here. In 1975, this is a illustration of if you are alive at, say, 65, what's your likelihood of living another 15 years? And if you look at the circles in blue, this is what it looked like in 1975 with cost on the y-axis. So while it's under $2,000 and there isn't huge variation, although there admittedly is some, you're not doing well if you're a United States citizen versus someone in Switzerland. Even back then there was a gap. But if you look forward to today, while everyone has gotten slightly better as your chance of surviving because life expectancy over the last 30 years has improved for a number of good reasons, not necessarily the delivery system. What you can see here is if you look at the square box in the United States that has sort of gold shading, that's where we are today. And if you look at that, we're still last. In fact, you can say we've trailed compared to other economically developed countries, such as Switzerland and Japan. And clearly, we are twice as expensive. If you flash forward to not only what it looks like today, the United States has gotten even worse. So I will share with you, we've gone more expensive in 2011, and we are less safe, so less likely you're going to live 15 years. And if you look at the New York data, it's more expensive and even a worse outcome. And what's not on this slide, because it got lost in translation, is Dubuque, Iowa, which is a very important thing because IBM as a purchaser has taken, and many may know that IBM is centered in New York as their corporate headquarters. When they look at placing jobs domestically, they just placed it about 10,000 jobs in Dubuque, Iowa, because their profile looks much more like Switzerland on this graph. Much safer for employees, but also at half the healthcare spend. So as an employer, this is an economic system. So when you talk to state leaderships, governors who are in charge of looking at Medicaid budgets and where the jobs are and where tax revenue comes from, this is a slide that looks at that economic situation. Companies are placing jobs. It's an economic imperative right now. Now, what I would want to let you know that unregulated fee-for-service is part of the problem. The over-reliance of rescue specialty care, no surprise to anyone here, but it really is about the delivery system's failure. And there are different degrees of who that shoulder rests upon, and probably all of us have to some extent some component of that. But that is also what I think is the opportunity to get it right. And on the next slide, if you look at what we think about for delivery of accountable care or patient-centered delivery models, and this is our Anthem approach. This is very similar to be it the triple aim or better to best approaches. It has to have these four pillars that we think will transform the delivery system and get to economic sustainability and solvency of states, as well as our entire country, as well as employers as they think about this. And this is relevant also to the pediatric space as we think about that smaller slice of the overall spend that's critically important. So meaningful reimbursement that's tied to what we'll call behavior change, but I would say that's value outcomes driven. So these are the things, if you think about an adult population, it's not okay to check someone's cholesterol. You've got to get them on the right level of statin if it's high to get them a normal cholesterol. Or you can make an analogy of it's not that okay that you just saw them for blood pressure. You need a normal blood pressure. And whatever the obstacles are for them taking that medication, that's the type of outcome that we need to look at. Clearly in the second pillar, expanded access is a critical issue for us. No doubt that is a critical access issue for pediatrics in particular, both in primary care but also in tertiary care, be it in the full spectrum that we need, all that Jim was discussing and alluding to. Clearly that's true for my specialty in pediatric cardiology, but it's across the board. For adults, that clearly is also an issue as we enter significant volume in the exchange environment. Access is going to be a real challenge, and we'll talk a bit more about what that looks like. There are many creative ways to do that, but that is clearly a need and a burning need that is going to become more of a problem. Care management coordination is a really critically important thing for those who spend their, most of their day in the delivery system itself on the front line, so to speak. How plans like Anthem can support that and extend it and support across the delivery system is going to be critical, especially when you think about the last pillar of this in terms of sharing our claims information as real-time as possible across the delivery system, but also any clinical information. For example, who is the at-risk patient? How do we get out in front of them to be able to support the delivery system to get a better health outcome much more early on in the process, less reactive, things that are very front and center for pediatrics, quite frankly. And if we look at what we are embarking upon, and I would share with you that of all of the things that is on the broad range of innovative solutions, I will share with you that patient-centered medical home type of behaviors, and in our company we are calling it patient-centered primary care, that is across the age spectrum is critical, because foundationally, if you don't have highly coordinated, exceptionally good, proactive primary care, no matter what you do in the delivery system, it's foundational for getting a value proposition that's sustainable. And so you will see significant investment by our company as well as probably others to looking at PCMH. I know that governments are looking at that for Medicaid programs and Jim alluded to a couple of states that have done that. I think that will need to be increased, because when we look at that product and what that looks like in terms of a result, both clinically and financially, it is the best option we have for sustainability long term. It's a lot easier said than done. But let me talk just very briefly about things that are either foundational and or what the future looks like. So enhanced fee-for-service or our pay-for-performance programs. We have that ourselves for primary care and pediatrics and family practitioners, but this is not just for primary care, it's across the delivery spectrum. We have a QHIP program, Relevant, which is our acronym for Quality Hospital Insight Programs. Think P for P for hospitals. So we have partnered with nationally endorsed metrics. We currently today do not have children's hospitals metrics, but we have discussed what that would look like simply because they haven't existed yet robustly enough. Now, there is stuff coming very quickly that some of you may be aware of. We have had a long-standing partnership with the American College of Cardiology and the STS, Society for Thoracic Surgeons, looking at things like CABG, PCI results, so percutaneous catheter intervention. And just recently, American College of Cardiology with Pediatric Cardiology Input are putting out the IMPACT Registry, which are national standards looking at pediatric cardiology outcomes. So there are going to be nationally endorsed metrics coming in that hospital space that are going to be really relevant and really important moving forward, which I just think is terrific and long overdue. PCMH, we are going to be seeing significant amount of investment by our company about really transforming and supporting it. Again, because we see this as not only disrupting status quo because status quo is unsustainable, but we also know that in thinking about access and the finances of it, this is where we believe there's a path forward. I would say that episodic procedures or bundled payments, which is predominantly today in the adult space, hip, knee replacement, spine surgery, CABG, etc., that is really looking at disrupting status quo, but on a short term from the economic imperatives of just how much unwarranted variation is out there, and predominantly looking at specialty and or inpatient. It's a part of the solution, but we don't think that it's the long-term solution. ACOs are a terrific potential opportunity for us to get across the care coordination delivery spectrum. I think, again, foundationally, primary care has to be there. And I do believe that in pediatric space, there's opportunity there. I will tell you that ACOs are great conceptually and separate from the actual entity where you have legal entities, contracts, gain-sharing arrangements. You know, our philosophy today is in our 14 markets, we have 6 active contracts that are working. From the full spectrum of care in Dartmouth and New Hampshire, we have multiple complex physician specialty groups in our California market, one just inked in Indiana. Several are coming in our other markets. The challenge here is scalability and whether they're there, because it is not our intent to put anyone out of business, but we have to be able to get at this. It's a lot easier said than done. And scalability, until we get some of the other foundational things right, may become a real challenge. But a lot of interest and space about understanding what that looks like. Global payments and risk-sharing arrangements are clearly here to stay, but they are not as simple as people might think at first pass. So on the next slide, if we don't do this, what if we don't go on this journey towards accountable care that we think primary care is foundational? Today, you just have more of the same of the fragmented experience, as you see here on the left. So you have multiple stakeholders sort of potentially working in silos, relatively speaking, and you have a fragmented member experience. And for those who are, say, for example, in the Pittsburgh marketplace where it seems to be most pronounced, if we do nothing what tomorrow looks like, or in honesty, what Pittsburgh looks like today, you've got lineup between delivery systems squared off. So University of Pittsburgh, for those who don't know this story, have a health plan. You know, fabulous thing. There also are other parts of that marketplace that have lineup, and they've been thrown out of each other's networks. We have very concerns about what that does to the potential for sustainability in long term, and I think that we have sort of better ways to do that. But if we don't do it, very concerning about what that consolidation and what that trajectory would look like in terms of just getting more of the same, and the finances we are, you know, very, very concerned about. So I mentioned earlier about the PCPCC. And this is a broad stakeholder support, and the American Academy of Pediatrics is clearly here at the table. Payers of multiple types, including our Blues brethren, as well as us, WellPoint, and the Anthem plans. We've been there since the beginning. Many of the Fortune 500 self-funded national accounts, almost 80 million lives, are there from multiple carrier relationships, as well as wherever possible, patient advocacy groups. And if you don't know about this, which likely many of you do, this is very important for informing policymakers and decision makers nationally. You know, we have looked at patient-centered care deliveries at primary care level with informing that process, looking at the pilot experiences to show that there is not just a better clinical outcome, but also financial results there, something that we believe in very strongly. Just one brief thing, because I have 2 more slides before we get on, and I think we're on track here for time. I would be remiss if I didn't talk about a terrific initiative coming out of the Innovation Center. And Jim talked about how pediatric thought leaders are discussing this with the Innovation Center. And I don't need to tell you guys that, you know, federal dollars from places like the Innovation Center would have to flow to state agencies, and there's, you know, 50 of those, each with a different bent and a different philosophy that have different budgetary constraints that's also dynamic. But that said, the Innovation Center has come out with, you know, under Don Berwick's former leadership, a lot of major initiatives, and these are terrific because this is also disrupting the status quo. So my Chief Medical Officer, Sam Nussbaum, was with the Innovation Center for the announcement of CPCI, which is the Comprehensive Primary Care Initiative. This is a multi-payer, multi-stakeholder intervention in 5 to 7 geographies across primary care to demonstrate to the Congressional Budget Office that there is a return on the investment. So the Secretary of HHS can go to scale with this if they're able to bless actuaries without going back to our Congress and Senate. That said, one of the land of unintended consequences and challenges of this application of the federal money as it flows was a requirement that the primary care practices have to have 200 Medicare eligible patients in their practice, which is a real challenge for pediatrics. Family practice, yes. And so this is that land of unintended consequence, well-meaning, exceedingly well-meaning. I've spoken directly with several of the people who wanted to do this, but you can imagine pediatric practice scratching their head about how you get 200 MA available patients. These are the types of things that continue to challenge, and it echoes the fact that pediatrics are not small patients. It's different. The federal dollars move different, and there are consequences of what those look like. And I couldn't echo more about, just like the analogy of the fact that we do not have enough specialists in pediatrics, we have to be very cognizant of what this looks like for pediatrics specifically, because really well-intended people, because of how systems are set up, can end up with unintended consequences. That said, on my last slide, some of the things in this PCP, or patient-centered, family-centered delivery model, in pediatrics, we know it's not just about the child who needs services, it's their family. It's also true for the senior population because it's usually coupled with a spouse and or adult child when you go through this. So really, truthfully, it's not just about the patient and their primary care doc going through and how we get to better access, quality, and cost. And some of the things that I haven't talked about but are important here. We have talked, I believe, a little bit in Jim's conversation about nationally endorsed metrics utilized across all stakeholders, be it commercial or federally or state level funding. That's critically needed in pediatrics and has not had enough attention, something we feel very strongly about. And so whenever we can get those nationally endorsed metrics, we need to do that. Alignment of the dollars to get a better total cost of care that gets quality and financial results is clearly important. If we go to the access issue for primary care, clearly we need to have our physicians and clinically licensed providers who can write prescriptions, for example, PNPs in the pediatric world, work at the top of their license. We need to actually fund for asynchronous contact in ways that don't require face-to-face visits, and new clinical delivery paradigms are clearly needed to be able to handle the volume across the care delivery spectrum. And lastly, something that is very much on our mind, which is a core competency of plans, because we have a tremendous amount of data, real-time, actionable, quality-driven, but thinking about it from the total health population management, but also realizing that health is delivered one patient at a time across the delivery spectrum. And getting that right and supporting it is not a simple or trivial exercise, but one sort of thing I want you to be thinking about that you may have heard about is that we partnered with Watson and IBM about taking the supercomputer that can learn. You may know that it beat Jeopardy, the savants who were the best Jeopardy people of all time. We sent, through our partnership with IBM, Watson to medical school to think about consuming the world's literature for evidence-based medicine. And it is our deliberate intent to reduce inefficiencies in the system that are administrative to start with, that incorporate evidence-based medicine based on our externally vetted medical policies is one example, but also to empower the delivery system. And our initiative in oncology is partnering with Cedars-Sinai to have them develop clinical protocols based on evidence-based medicine using Watson that never tires, that can consume evidence super fast, that can prioritize the evidence of what's going on there. This is not WellPoint or Anthem deciding. This is the delivery system telling Watson how we should do this and use this as a clinical resource. This is like up to date, not just on steroids, but a whole quantum difference. That type of learning in a high-performing learning network is likely going to be needed in pediatrics, as it is regional rather than state-based in terms of how things move forward. And so these are some of the thoughts that I would like to share with you, and I appreciate the time. So at this point, I think, Ken, we're going to launch our next polling question.
Thanks. Thanks, Peter. Sorry about that. With your comments in mind, I'm going to launch our second polling question. The question is, how is your organization preparing for pediatric healthcare reform? Please respond by clicking on the response that best applies to your organization. The potential responses include developing closer ties to subspecialists and pediatricians, developing a pediatric ACO, implementing a medical home model, enhancing information system functionality, and evaluating global payment methods with third-party payers. We'll provide the results in just a moment. Actually, I have a question that came in from one of the attendees, Peter, for you, and going back a couple of slides, was wondering if you could reiterate or restate the point about the 200 patient requirement with regard to the CMS Comprehensive Primary Care Initiative, just to clarify that.
Yeah, I'd be glad to. This is something that, we have been extremely supportive about this initiative because the multi-payer, multi-stakeholder, so self-insured large clients, local funders within a geography, delivery system, conveners in a system, so the people have learned how to do it and deliver patient-centered primary care. And the Innovation Center is absolutely committed to doing that. They appreciate that this is exactly, primary care transformation is exactly what they want to do. In this grant application, because of how Medicare is structured and the innovation is structured, the intent was to get a sizable enough population base so that when we look at the clinical outcomes of improved quality and the financial results, to look at that byproduct, which is really a value proposition, the critical mass of Medicare and commercial populations was their design and intent. And it was specifically intended to go after the full delivery of healthcare specialties. But for the money to flow, the challenge that the Innovation Center had was needing to have sufficient Medicare or MedAdvantage, so either fee-for-service or MedAdvantage population in the primary care practices. That's a colossal challenge for pediatrics. And so at the end of the day, the CPCI initiatives may include some significant pediatric through family practice and or large multi-specialty provider groups, but for sizable small or sizable pediatric discrete populations, it may be a real challenge or what I would describe as, unfortunately, as a non-starter for pediatric practices because it's exceedingly unlikely to have 200 Medicare eligible people in your patient panel. It's sort of as simple as that. So this is not a knock on the Innovation Center by any means. The CPI grant is incredibly important for demonstrating transformation across multiple stakeholders. But because of some of these, unintended consequences of how the system is structured, it ended up that way. In the pediatric perspective, that was to clarify my comments. And so I talked long enough, and I'm sure you want to get to the polling results.
Actually, Peter, if I could jump in for 1 second related to that. I mean, one of the challenges that we've had with the Innovation Center overall is they're very Medicare-centric, and the only kids that qualify for Medicare are generally those on end-stage renal disease. So you're talking a very, very, very small population. So as you were talking, that 200 would be impossible for any physician practice to actually achieve that for pediatrics.
Yeah, that's right, Jim. And I think with the exception of family practitioners in select geographies that might meet some pediatric patients coming through that particular model, and
but they're not going to be Medicare covered.
Well, so the rule says that your whole practice can participate if you have 200 MA or Medicare eligibles. So if you're a family practitioner in a large practice in one of these geographies, you see some pediatrics as well as some adults commercial, but as long as you have in the practice, the entity, the provider practice, at least 200 Medicare eligibles, you will get the full spectrum. So everyone in that practice will be part of the delivery model, provided you have the 200 Medicare eligible. So it's a subtlety of it, and I don't want to get caught up on it. It just illustrates, again, the challenge of the fact that federal money goes to states for pediatrics, and it's not really coming directly from CMS, as you pointed out, Jim.
And that's what I just wanted to clarify. No, I agree with that.
Yep.
Thanks, guys. As the poll has closed, let me read through the results. To the question, how is your organization preparing for pediatric healthcare reform? The first response is developing closer ties to subspecialists and pediatricians at 74%. Second response, developing a pediatric ACO at 21%. Implementing a medical home model at 51%. That's interesting. Enhancing information system functionality at 74%. That's probably something that deserves a little bit deeper dive because we're always interested in enhancing functionality of information systems. And then the fifth and final, evaluating global payment methods with third-party payers at 46%. So a lot going on here, a little bit in the realm of pediatric ACOs. Peter, any thoughts or responses? Any surprises?
Yeah, I wouldn't say that I'm surprised about it. I think that if we are, I'm going to go with the assumption that many of our respondents are from pediatric, inpatient systems, and I'm going to start with that assumption, which I think is probably valid. I do believe that both for pediatrics and beyond, getting closer ties to the delivery system that's outside your walls for your first response, getting closer ties to subspecialists and pediatricians is, I think, important because to be able to interface and care coordinate, you need to do that. And I think that the IT system functionality to be a data-driven outcomes entity that will then help with the financial risk moving forward to be able to be fiscally sustainable is very smart. Personally, I would say that we would want all that are on these 5, but in terms of where these land, I think that I wouldn't say I'm surprised. I think that if about the medical home specifically, I think that if you're just at 50%, it may be because some of the participants aren't close enough for that footprint in primary care, but those that do, in terms of thinking about that as foundational to sustainability, that as third is probably my gut reaction to the poll. So I think that's on the money for me.
Yeah, thanks, Peter. We do have a third polling question I want to move through here, and we'll move through it relatively quickly. I'll go ahead and launch that. And the question is, what is the most significant challenge your pediatric organization is facing in 2012? Please respond by clicking on the response that best applies to your organization, and those include Medicaid payment levels, commercial payer reimbursement and payment reform, competition from other pediatric providers, internal restructuring and improvement, or partnership development with other providers. And we'll provide those results in just a moment as folks are hitting their response buttons. Another question actually from one of our attendees for Peter, and I know you spoke to this, but maybe you could just go into a little bit more detail. The question is, what specific steps is Anthem taking to support the PCMH? And I know you went into some detail and provided an overview. Is there anything more specific that you can say briefly about Anthem's specific steps?
Yeah, no, that's a terrific question, and I appreciate it. So we if you think about primary care transformation, which is how I think PCMH has evolved from. I think most people on this phone know that patient-centered medical home began in Hawaii for the need for children with special health care needs, because the pediatrician there who coined and realized the need understood that there needed to be a single sort of place where this all came together. And I think that next generation patient-centered medical home is sort of having the one place you can go in the complex delivery system where you can coordinate all of your care and get first contact with care so that it's not fragmented. That said, we in our states have 10 patient-centered medical home initiatives that run from urban to rural initiatives. All but one of them are multi-payer. They span 6 of our markets today with PCMH-like activities in all of our markets at this point. I will tell you that in one of our geographies in our downstate New York initiative, we actually went it alone because we couldn't get other payers to actually join us, unfortunately. And so that has to do in Westchester and the 5 boroughs of the city. And I think that what we have learned from that experience is that we have seen very positive clinical improved outcomes as well as fiscal improved outcomes. With that, we have embarked on understanding how we can take that to scale. And if you think about what that means transforming all of our 14 geographies that we are relating with the network to deliver patient-centered primary care. And with that, it is a gargantuan undertaking, but that is a journey that we want to take with our network. There are several in our market that were ahead of us, and we are catching up to them. There are those in our marketplace that aren't ready to do that, and we want to help them along that journey to begin that journey and understand what the key elements are, what those investment obstacles are. We did learn that merely becoming NCQA certified is not the way to approach this, because you can actually get certification but not transform. And as we connect the fiscal incentives and align it to transforming and support it with data and support it with care management, that's our, that is where our journey that we're going on. In 2012, you will be hearing about, and even in external, fairly visible format within the next couple of weeks, or actually in the next days, about our patient-centered approaches. So there's going to be a lot of that coming from the bottom up. And so this is a journey that we are, this is not about just sort of doing something looking for press releases. We have very deep local penetration in our 14 markets because of our presence across the Blues, and that's something that we want to help transform from the ground up. So appreciate the question.
Yeah, thanks very much, Peter. Just to review the last poll then, the most significant challenge of your organization in 2012, 54% Medicaid payment levels, commercial payer reimbursement and payment reform, 8%, competition from other pediatric providers, 6%, internal restructuring and improvement, 17%, that's our second highest total, and partnership development with other providers, 15%. Not surprising which is the highest. Interesting in reflection from past years, the competition question is so small as to almost be inconsequential. Any comments from any of our speakers on the results?
Well, maybe I'll start, and I'm sure Jim would want to weigh in. I do think, as Jim very, cogently articulated, the Medicaid payment and reimbursement is a major issue. As a commercial payer, proportionally speaking, we know that the private funding sources disproportionately make up for Medicaid underpayment as it is today, and the future looks even more perilous. And so I think that that Medicaid payment level and working in your local delivery system with the key decision makers at the state level and nationally whenever possible is I do think an important and really critical thing that it faces the near term.
Thanks. Actually, in the interest of time, I'm going to go ahead and move forward just so we get the rest of get through the rest of the presentation and get to some questions, other questions that we might have. I'm going to go ahead and turn it over to Mark now. We're going to co-present this next section. We just want to give you a flavor for what we have in mind for our webinar series for the rest of the year. Mark?
Yeah, thanks, Ken. The discussion that we've had, actually has teed this up, and I just want to highlight, a couple of things that come out of the discussion in this slide that we've heard. One is the switch from reimbursement to payment and what that means. The second, who bears the risk and what are the right structures to push forward. The third is how do we get value and appropriate metrics. And the last that struck me was we want to look at across the age spectrum. And as you think about those things candidly, the answers, I think, to our poll were a little bit surprising to me, because one way to look at those is they're notwithstanding the need for reform in the system, and I think a uniformity of view that the amount of dollars going into the system are not going to go up. If we look at what Moody's came out with very recently, Moody's saying that the top line revenue for not-for-profits is not really going to move. That suggests to me that there might be an increased focus on changing structure such that the amount of funding may remain top line flat, which will impact the distribution of funds among the participants going forward, which in turn will require different structures and infrastructure in order to allocate those funds. And so as we look at what we're talking about in terms of health system reform, you put that against the announcement this week between the Boston Children's and the Blue Cross Blue Shield of Massachusetts about a global arrangement with a 0 rate increase for 2012, modest increases over the next 2 years, with what they call the alternative quality contract with a focus on agreed clinical outcomes. I wonder if the questions elicited something that's slightly different than where the leading edge of this overall delivery system is going to go. What we hope to do in the next session, which is sort of at a macro level encapsulated in slide 38, is we're going to look at how do you address this challenge in the system structurally, whether it's capitated contracts, episode of care, whether you need a program like Nationwide has in their capitated approach, or with captives and carrier arrangements like Texas Children's or others going down to Pittsburgh, as to how is this competition going to be driven by reform, with the question at the bottom of the slide, are we really going to see merger, acquisition, and consolidation, which we keep increasingly becoming involved with in this space in our practice? Ken?
Thanks, Mark. That's a great intro to I think our series for the year. Other topics include one that's on I think everyone's mind, and that's subspecialty physician and hospital alignment. We've seen factors over the past probably decade driving greater alignment among medical schools, hospitals, private practice physicians, faculty practice plans, et cetera. And a number of those current reforms related to healthcare reform discussed today. But the overarching issue here, of course, is shortages in pediatric subspecialties that we have seen, and a number of organizations are continuing to see and document, including NACRI and ECG and a number of others. So our next webinar topic intends to explore some contemporary structures and relationships between hospitals and physicians in order to create the type of alignment that's necessary in order to move forward and accomplish some of the things that we intend to with healthcare reform. Employment models as opposed to contracting or other types of arrangements, and then overall integration and how that's accomplished among multiple organizations, physician groups, and hospitals and across hospitals. So that is obviously a key topic on everyone's mind, and that I think will be the second of our webinar topics. Mark?
The no program in healthcare delivery today would be complete, regrettably, without talking about fraud and abuse and compliance issues. Although we're heading off of the Medicare space, there's obviously a great deal of federal healthcare program dollars flowing into the various children's programs. The anti-kickback statute continues to apply. One of the areas that is very important in this space is the 340B drug pricing program issues. Recent OIG review from last year expressed concerns about whether this was appropriately being managed. Issues related to discharges, readmissions, particularly in this space. More bad news, I mean, we heard about dollars at the top line. More bad news was the health reform expansion of RAC audits into the Medicaid space, something I'm sure everyone is not looking forward to. We'll also have an opportunity to examine the OIG advisory opinions that have focused on pediatric and children's issues to date. We'll probably take a quick look at the application of the academic medical center exception into this space. And lastly, I don't want to overlook the fact that as a result of PPACA and the Healthcare and Education Reconciliation Act of 2010, there actually was an amendment to the definition of remuneration, which added an exception for remuneration which promotes access to care and poses a low risk of harm to patients in federal health care programs, which particularly in the pediatric space may provide some additional opportunity for flexibility. Ken?
Thanks, Mark. Yeah, another topic that we intend to explore is the impact of research and teaching in this space, in pediatrics and children's health care. And I think Jim alluded to this earlier, but because of the nature of the types of programs and centers that we have, there's a very high proportion of those of you who have academic programs. In other words, you're committed to the tripartite mission of clinical care, teaching, and performing research as well. And we heard a little bit about Children's Hospital, GME, and of course there are, for those of you in larger systems, there are pressures that you all are feeling related to traditional GME funding as well. So the topics that we'd like to explore there are how we protect that and manage our investments, how we look at collaboration challenges with private industry as they become a significant financial source for research in particular, and bringing those new treatments and innovations to market. Challenges associated with for-profit and not-for-profit collaboration, and then special issues including consents and clinical trial challenges, realizing that the academic enterprise is something that most, if not all of you, are managing at the current moment. Another key topic that we kind of talked about, addressed just briefly, but was alluded to in a couple of the slides, is information technology, and how those challenges are unique in pediatric healthcare. Similar to adults, there's the need for community integration and engagement, and also the need to optimize IT investments. But we also have unique challenges related to the span of our programs, the fact that we tend to cover larger geographic areas and need to integrate with community systems, pediatric general pediatricians, FQHCs, and other organizations that are out in the far-reaching areas of our market areas. Topics include our EHR incentives and Medicaid programs, how we engage those primary care networks, many or most of which still are private freestanding practices. Special needs for those programs where we have centers of excellence, including cardiac care, oncology, and those quote-unquote flyover programs where we attract patients from all over the country or from more of a regional network. And then finally, opportunities for telemedicine. Given our shortages of physicians and the inability to be everywhere all the time, how can telemedicine help us meet the needs of our pediatric populations? And then finally, we have subspecialty physician practice. What we'd like to do is provide an overview, I guess, of the state for subspecialists and surgeons in pediatrics and their physician practice and in those attributes. Again, what we've seen over the past decade is downward pressure on professional fees and growth in Medicaid. And Jim actually provided a real cogent example of the coding differences and payment differences between Medicare and Medicaid. Compared to commercial reimbursement, it's even more stark. But we've seen that happening. We have ongoing shortages, I think is pretty well documented, and continuing escalating salaries because of the shortages and the lack of new physicians coming out of GME programs. So as a result, we have statistics and topics to explore, I think, with you all around subspecialty physician shortages, around the needs, the recruitment trends, what you all are experiencing. We have some survey and other data that we can share with you around compensation and production trends, and have a good discussion around those topics and other professional practice characteristics. With those comments about what to expect in the coming series, I'd like to transition to the Q&A section. First of all, I'm sure that our webinar audience joins Mark and I in thanking our presenters for sharing their thoughts and experiences regarding the healthcare delivery system in the state of the state. Certainly, the audience is invested in this topic, as evidenced by your many questions that we've received. We'd like to move on to some questions. We realize we're running a little bit over, and so we may have to cut off without answering all of them, but those that we don't answer within the session, we will get back to you directly and specifically. We'll answer as many as we can in the limited time that we have. So I'd like to start off by asking a question. I think this is probably best addressed to Jim and potentially Mark, but the question is, do you anticipate that FQHCs will be a significant strategic component of the pediatric delivery system? And just a bit of background, an FQHC, of course, is a federally qualified healthcare center. They have separate organizational structures, and given what we've heard about partnership and the need for primary care medical homes and integration across systems, I think it's a particularly relevant question. Mark or Jim, would you like to address that?
Sure, I can take a first stab at it. A lot of the children's hospitals actually have close working relationships with the FQHCs right now, and there is actually some funding in the Accountable Care Act to help the FQHCs expand their hours of operation, sites, etc. But one of the things we hear from the FQHCs in the partnership is often related to specialty care. While they can do the primary care, they don't have access to the specialists, and with the children's hospitals employing large numbers of specialists, we are basically a major referral center for them in that partnership to make sure the children receive the care that they need.
You know, I think FQHCs have a great opportunity by closely integrating with children's hospitals to provide a significant portion of the primary care, but move the reimbursement system away from the pure Medicaid system in order to get compensated at significantly higher levels. One of the challenges of the structure, however, is that the FQHC governance requirements and sort of fee schedule requirements sometimes are not the same as the hospitals would care for. So to be able to develop a close working relationship with what may be an independent board housed within the four walls of the hospitals, in some cases has proved challenging. In others, it has worked out quite well and allowed there to be, as I say, a significant integration plus an increase in reimbursement. That particular structure is one that I think we're going to explore when we talk about hospital-physician alignment.
Okay, thanks. Thanks, gentlemen. Here's another question. This looks like it's more appropriate for Peter, and it is, the question is, how is your patient-centered primary care collaborative handling behavioral and psychiatric care?
That's a terrific question. I will tell you that when you look at the comorbidity of the value outcome of members who have behavioral health issues, it complicates both the finances as well as the ability to get a better clinical result significantly. You know, primary care understands that fundamentally, and there is not sufficient capacity, but also understanding, not to mention sort of the headwinds in the general public about you know, sort of taboo around behavioral health, although we have made significant strides. And specifically, I want to talk about not the extremes of behavioral health, but really garden variety major issues. Just take the widespread under-recognition of depression and how it impacts chronic disease throughout the age spectrum. It's tremendous opportunities for improved care coordination that is going to have significant improvement. So I think that from a primary care foundational perspective, behavioral health is on our extremely short list of where to begin as we take that journey. It's an excellent point, excellent question. I appreciate people bringing it up.
Okay, thank you. Here's a question. and this is probably for, actually there's two that are related. I'll ask the first one to Peter. What does Anthem and other for-profit insurers believe is their role in supporting the cost of medical education?
So it's a great question. I think that the way that we support medical education in this country, sort of depends upon where that, goes through, right? There's medical school and then postgraduate training, et cetera. The funding of training in our country is a curious one. I mean, we have done some work of after, sort of training, if you will, in terms of trying to support that type of, what the needs are. But we have not done a tremendous amount of what that, or how that sits. To be blunt, I don't actually necessarily think that there's going to be a tremendous amount of activity of funding the medical education, at least not that I've seen at this point in time. That may change, but I actually don't see that in the near term.
Good. Okay. Yeah, that's a very good question. It's something on a lot of people's mind. Another question actually related to that is, do you think, let's see, given the current financial pressures and emphasis on clinical care, do you anticipate that pediatric programs will be reducing investment in academic programs and research in particular? This is probably a question more for Jim and what he's hearing among constituents and those invested in the academic enterprise.
That's a great question, especially for the freestanding children's hospitals. Like I said, they were training about 40 to 43% of the pediatric specialists and the general pediatricians. One of the issues that we're facing there is currently, because it's a discretionary appropriation, and like the Medicare GME support, the freestanding children's hospitals are only receiving about 70% of the per resident support that the adult hospitals are receiving for training. And the children's hospitals are shouldering a significant piece of the training of the next generation of providers. While we have not heard that they're going to scale back, but one of the things that we've heard many of the hospitals talk about is if that program is not funded, is not reauthorized, and with the continuing challenges that the hospitals are facing on Medicaid, they're going to have to look very, very carefully at what they can continue to do. So, while we don't see any short, scale backs in the near future, I do think if there's continued financial pressure on both Medicaid and the CHGME program, you will probably see some reduction in training slots in the future.
Interesting. I think we've got about enough time for one more question, so I'll answer this one. And we appreciate those of you who stayed on a little bit over. And thank you also for our speakers for staying on and answering these questions. This one I think is, well, I'll ask the question, are we likely to see significant merger and acquisition activity in pediatric programs in the next 12 months? We heard a little bit in our polls about some interest and focus on those types of partnership initiatives. But a question maybe perhaps for Mark to start with. Do you think we're likely, based on what you've seen and have spoken with your clients about, to see merger and acquisition activity?
Yeah, thanks, Ken. I do, and I think it's driven by a couple of different things. The first is the cost pressure. I think the cost pressure suggests that to the extent that programs where it's part of a larger program or embedded in a different program, the pediatric and children's care alignment with other institutions who have part of those programs and try to consolidate the costs involved in that space, I think makes a lot of sense. The second is, if you're going to have the necessary volumes in a variety of pediatric specialties, and you're going to see the increasing challenges of recruitment, it's going to force some sort of consolidation in the patient population, I think, in order to generate the patient base that you need in order to maintain high-end quality programs and justify continuing investment. So I look for merger consolidation or sort of structural alignment by joint ventures in order to try to address both of those types of issues.
Yeah, I'll just add, I think you're right. I think you're going to see some changes. I'm not sure it's going to be mergers and acquisitions, But I think because children's hospitals especially are much more regional providers, I think you're going to kind of continue to see that regionalization play out even more, especially as they have challenges in getting the pediatric specialists to provide some of those programs that they need. So how can you use health information technology, telemedicine, other opportunities to partner and have a greater regional reach?
Thanks, gentlemen. Given the time, I'd like to, once again, thank our presenters for sharing their expertise and insights with us, as well as everyone in the audience for setting aside some time of your day to listen. This concludes our webinar today. We'd like to ask you to take a moment to complete the electronic survey upon exiting the session. We hope you'll join us for other upcoming programs in the Pediatric Business and Healthcare Delivery Series. If any of you should have any further questions about this session, the series, or the subject matter in general, please feel free to contact Mark Waxman or myself. Our contact information can be found on page 2 of the handout you received, and we look forward to hearing from you. Thank you, and have a great afternoon.